Good morning, everyone. My name is Tim Moore. I'm director with Smart Source, and we're pleased today to have Dr. Ian Madom. He is one of the co-founders of Mockingbird and currently serves as the Chief Strategy Officer for the company. He is an acknowledged expert in all aspects of CME, continuing medical education. Welcome, Doctor.
Hi, thanks for having me, and thanks for starting off this conversation. I appreciate it.
Yeah, no problem at all. I hope this will be enlightening and illuminating for a lot of people in the industry. So let me ask the first question. As a practicing physician, what does innovation in healthcare mean to you?
I mean, I think it can be a broad answer to that. So I'm a practicing orthopedic spine surgeon.
Right.
And as people know, orthopedic surgeons like their toys, lots of widgets that are out there. And I think that over the past, 10, 15 years, innovation has really focused on coming up with new actual device and intervention type of technology. And I guess broadly, you can think of, I think of innovation as something that serves the purpose of either improving a patient outcome or patient experience. But now, even more broadly, should be thinking about not just the patient, but also the provider experience in delivering healthcare. So that's where I see innovation going, moving away from, hey, how many different widgets can we build? How many, in my world as a spine surgeon, oh, we have this type of screw and we have this type of implant. But more important than that is the processes, how healthcare is delivered. So in my world, in my work world of being a spine surgeon, it's the thinking of the different phases of care of how a patient is taken care of, but now translate that into the patient, not just the patient experience, but the provider experience. So how do we improve on the delivery of healthcare to improve the experience of the provider so we're reducing that administrative burden?
So that's what we're drilling down today on, that the licensing and the continuing medical education. So let me ask the question, how does having multiple licenses help a medical professional?
So classically, people have shied away from going after multiple licenses because it's just a lot of work. And unless you lived in a certain area, it didn't really make much sense. I grew up in Long Island, went to NYU and spent a lot of time in New York City. That's a classic place, right? It's known as the tri-state area. So you have Connecticut, New Jersey, New York. A lot of people carry those multiple licenses. There's a lot of places throughout the country where people sit in areas where, people are coming from Kansas or Missouri, or up in the Boston area, New Hampshire, Maine, Massachusetts. So there's many different areas around the country that are like that. That is now more broadly accepted with telemedicine becoming more popular because, I think of the situation where I practice in Rhode Island, a small state. I see patients in Connecticut and Massachusetts. So me having state licenses in those states can help me reach those patients so they don't necessarily have to come into clinic. But I also live in the southern part of the state. Yes, Rhode Island does have a southern part of the state, even though it's tiny.
All 10 miles of it?
That's right. So, and in my part of the state, a lot of people disappear and go to Florida for the winter months. Well, wouldn't it be great that I'm able to connect with those patients in the wintertime and have a Florida license? I'll tell you, I have no interest in trying to maintain that many licenses without a way to manage all of the administration that comes along with it. Because in my work, just like everybody else's workplace, we have administrators that can maybe help you, but they're managing multiple providers. And I end up with a last minute email about, hey, you have to get this training done. And there goes my weekend.
Yeah. Understood. And that leads into my next questions. What are the challenges of licensing and in the current CME process as you see it?
So I think it really comes down to managing all of the processes around keeping that license and the new rules that come out year over year. Um, and I think that the intent is good behind those things, right? Rhode Island added that all providers have to have some type of Alzheimer's training every couple of years. Well, I can see how that's beneficial because we have an aging population, and it impacts an orthopedic surgeon the same way it impacts a internal medicine doc.
Sure.
But it just, they continue to increase every year, and you find out last minute. In Connecticut, you have to do human trafficking training, and everybody has their opioid training, but one state may not accept every type of opioid training. It might just be a specific training they need. So that becomes way too involved for a healthcare, a clinician to manage, because what did I go to medical school for? I went to go learn and do my residency to take care of people, not to learn how to manage a license. So that's the biggest hindrance there. And when people think about taking on more licenses, that's not something that you think of necessarily beforehand, but you're sure as heck realize it really quickly after the fact. If you want to manage it, now you've went through all that work of getting the license, you really should keep it. And it's not that much, the education is important, right? Like
Right.
the learning part should be the focus, not the, hey, what do I need to do and when do I need to do it?
Yeah. So I think you're speaking to the inefficiencies of the current process, right?
Yeah.
At what point does it become too much? And
Yeah.
it sounds to me from where I'm sitting that it already is too much for most medical professionals, right?
Yeah. I mean, that's
Okay.
where, people talk about burnout, and, burnout, it's almost been a little bit overused, and people are pivoting now to talking about provider wellness or clinician wellness, which I think is a more broad term, and I like the term. But burnout is something a vacation doesn't fix. That's one of my, one of the people I work with. She found that quote, and I like it because it's true. It's something that a vacation doesn't fix, because it's a process issue. Anytime people talk about burnout with clinicians and say, let's do resiliency training, you're talking about some of the most resilient human beings that we have go into healthcare, because it is challenging on so many different fronts, intellectually, socially, just the emotions you carry around with you on a day-to-day basis on taking care of people, and that stuff, that burden that you bring home, that you lay in bed thinking about your patients at night. It takes a resilient person to do this job on any level. And to try to say we're going to increase the healthcare, the clinicians' resiliency, that's going to fix their wellness, that to me is nonsense. It's a process issue. Let's make better processes for the people who are doing the job, so they can do the thing that they love, which is take care of people, not do the things that they hate, which is dealing with paperwork and billing documents. And we have to do it, of course, but there's got to be a better way to manage all of it.
Okay, so what made you decide to tackle the challenge of the tracking and all that?
It became an issue that it's been an issue for me for a while. I went back to business school in 2015 at Yale School of Management. I met my co-founder, George Fernane, who's a interventional cardiologist at NYU. And we spent time during our classes, and we talked in between classes about, we did the doctor's favorite pastime, complain about healthcare. That's what docs do. It's funny, when I was early on coming into it, I used to complain. I used to tell my father, who was a pediatrician, you complain too much about healthcare, just go change it, do something about it. And then I became that same person. So I became my dad very early in life. One of the things we started talking a lot about was how we were having a hard time during business school, even more than usual, keeping up with the new requirements that were coming out, because there was a lot of new requirements coming out during that 2-year period. And we just said, well, why we keep talking about this, but there isn't a system out there to fix it. We had both talked a lot about fixing things from within healthcare, but never really considered an entrepreneurial route to solve this problem. So we just started doing a bunch of research with our colleagues, saying, is this a pain point for all of you, or is this just something, George and I are feeling?
Unique to you,
yeah. And it certainly was a broad feeling. So we decided to tackle it, understanding that, we have a passion for solving problems for our fellow healthcare providers, right? That there are lots of solutions out there that are offered for hospitals and systems, and solutions that are obviously offered for patients, as they should be in healthcare, but not really many people focusing on the provider experience, or it's the fourth pillar of
right.
the quadruple aim, not just the triple aim that Berwick talked about in his famous health affairs article that the ACA is built off of, right? It's improving population health, improving outcomes, and improving value, outcomes meaning the patient experience and the value that we offer, quality over cost. So the fourth part of that is improving the provider experience, because if not, we're going to keep losing people early on in their careers, and that's a waste of resources and really a waste of talent within our healthcare system.
Would you say your mission goals when you started Mockingbird have morphed, have changed? How would you address? Did you start off at one point and go to another point?
It's funny, we still, we have brought on now this team, because we're still practicing full time. So there's a full team that is running Mockingbird right now, and we still stay intimately involved on almost a daily basis to keep those values alive. I think that we've really embedded them really well, but that is the core of our mission, is to improve the clinician experience and improve wellness through improving process, right? And we feel like that's the real route to making people happier in their work lives, which will make them happier overall, because they'll feel more fulfilled. The way that we want to do it is say, let's take a lot of this administrative work away from you, automate it, and be able to deliver to you what you need, which is the education, so that you are better equipped to take excellent care of the people that you care about.
So that leads into my next question, which is, what question are you most tired of being asked about CME tracking or Mockingbird in general? What do you hear over and over again you're sick
of? The thing that people, I think, confuse in this whole process, and they ask us about, is, are you a credentialing service? And we're not, right? The credentialing market is pretty crowded. There's a lot of players out there that do it, right? And credentialing, what I mean by that is, I have my credentials from my college, my med school, my residency, I have my licenses, and then I go and I get credentialed with either Blue Cross in the state of Rhode Island, and I get credentialed at, certain hospitals so I can have admitting privileges. And those are an event here, and then a period of time goes by, and then an event here. There was nobody filling that gap, right? It was by the time we got to that second point here, it was administrators scrambling, where's all this stuff, Dr. Madom, that you supposedly had done? And I'm like, I don't know. And I'm flipping through emails and files and paperwork. The whole intent was for us to fill that gap, so that credentialing, and this is what our CEO says now. I think it's a brilliant way to think about it. Credentialing becomes a non-event because it's all kind of
It's already been done.
Yeah. It's already been done. We're delivering the stuff around. So, people keep confusing, and part of that's our job, right? Is to deliver the right message of what we do. And I think that over time we've gotten better at that, and people are starting to understand it, and it starts to resonate with people that it's about the time in between that we can deliver on what the ongoing requirements are, not the actual credentialing event.
Right. That's really interesting. So, okay, so my last question for our little interview, what's the one piece of advice that you would give someone who is just entering medicine, the medical profession today?
So I think that it's hard for me to give just one.
Well, okay, then don't give just one. Give as many as you need, because I think it's all good.
Yeah, I do think the one piece is to really, as you're just entering medicine, so even let's say you're entering medical school, is to of course always focus on your education, on the learning to learn for the rest of your life, right? That's going to be a cornerstone of healthcare. That's always been, and I think it always will. It's why we do research. And I have some friends that are, scientists in the sense of bench researchers and folks like that. And they don't consider doctors necessarily scientists all the time. But I think, we are, because we do research, we read research, and we're constantly learning, and modifying our practice. So you have to keep your mindset in that, but you also have to realize that there's a system out there, and this system has been built with layer over layer over layer over layer, and it's not necessarily a well thought out system when it's built like that. I think of it, and I'm not trying to be pejorative towards Boston. I am a New Yorker, so take it for what it's worth.
So it's okay.
You drive around Boston, you're like, where are these roads going? And it was a city that grew from this, and it grew out, and there was no plan, right? Whereas you go to Manhattan, right, and it's this way, and it's planned out. It's pretty easy to find your way around. Not saying that New York is better than Boston, even though maybe it is, because from my perspective. It's that you need to realize that the system is broken in certain ways because it's been layered over time. And the only way that we're going to fix delivery of healthcare is if we all dig our hands in and really become involved with changing the processes that are inefficient, because that will if we do that, we will be able to deliver better outcomes for our patients. Our healthcare, the actual care of people will improve in the United States, and we will be happier doing it because our patients will be happier. So everybody wins if we start to really dig in on those processes.
So easing the reporting requirements makes a happier doctor, makes a more likely a better outcome for the patient, a win-win. Explain a little bit about how Mockingbird works, just in general terms, if you would.
In general terms, we are a rules engine. So we have the rules for all 50 states on what's required to maintain a license for a MD or DO or an advanced practice nurse or an RN or even a physician assistant. We have the rules for the American Board of Medical Specialties. All the board specialties, we have all of those rules listed out. And what I mean by rules engine is we don't only have the rules, because you could go find the rules, which by the way, sometimes are incorrect on the websites. We go directly to the legislation. What are the rules? On the websites, we've actually corrected some Department of Health websites and saying, hey guys, this is not what the legislation says. You guys have it incorrect. And that's where we do our research from. We then have an engine that takes that, puts it into code, and organizes it in a way that tells you when those things are due, because it's all asynchronous, right? My state doesn't line up with my American Board of Orthopedic Surgery. State to state doesn't line up because they don't all renew at the same time. Some renew on a specific date, sometimes in the middle of the year, sometimes on the third month of the year. Sometimes it renews on the clinician's birthday, right? So it's always different, always asynchronous. And having a rules engine not only takes the rules, but then codifies it for that specific individual. What we can then do after, and this is like the secondary value proposition, our primary one being that rules engine, is to say, okay, Ian, you're an orthopedic surgeon who practices in the state of Rhode Island. You have a license in Massachusetts and Connecticut as well. You need this many things, and you like to learn about these things. Let me start giving you the right education, the right place at the right time. Maybe delivered on your mobile device. The American Academy of Orthopedic Surgery, my academy, still sends me things on knee replacement and hip replacement. I haven't done those in 15 years, right? I only do spine surgery. So I want a system that delivers to me not only stuff on spine surgery, but what is it specifically like? Maybe I like to hear also about things on the delivering, pain management in the post-operative period, or on nutrition, perioperative nutrition management. These things, we have a platform that's going to be able to learn about what you're interested in doing, so that we can say, okay, here's 3 opportunities for education, all 3 things you were potentially interested in. Now we can tell you, well, the top 2 apply to your boards and all 3 of your licenses. This bottom one might be a little less expensive, but it only applies to 1 of your state licenses. And then we can also start to work in some peer rating. So it's just going to improve the efficiency of learning, at the same time keeping people on track so that they're never falling behind.
So your basic goal and aim, and I get it, is to reduce the background noise so that people can learn easily, quickly. The reporting, you're easing that reporting, so that medical professionals like yourself, have the time to really focus on their patients. Ever learning is a great phrase that I adopt, because I know in the health. Where do you see healthcare going in 5 years, 10 years? I know COVID's put everything on its head, but
yeah,
point of forward vision.
That ever learning process is important, right? Because I'm going to get the exact numbers wrong here, but the gestalt kind of you'll understand is that, back 25 years ago, I believe it was 25 years ago, the amount of medical knowledge, new medical knowledge, doubled I want to say it was every 5 years. It may have been every 10 years. And 10 years ago, it doubled about every 3 to 4 months. Now it doubles almost daily. Like the amount of knowledge that's out there. So first of all, there's got to be filters out there that filters out like what you're saying, the noise from this good stuff that I can go and give my patient better care. So we just need processes that can filter, right? Filter out good knowledge so that we can translate that into our practices. The actual delivery of healthcare needs to be more efficient as well. So in 5 years, COVID, you bring up COVID, the changes, telemedicine has been a huge change and really opened up an opportunity for care, opened up a Pandora's box for the administration of care that we weren't really ready for. But the delivery of care through telemedicine, you asked an orthopedic surgeon even a few years ago, people were like not interested, right? It was 1 to 2% of people. And during COVID, the number jumped, right? Because we had to. And the number has come back down in orthopedic surgery, but I'll tell you, it's not staying down. It's growing faster than other places. And you'd say, well, why is that? Well, orthopedic surgeons put their hands on people and they examine joints and examine backs. But even our journals, there was a recent article on how do you examine a patient through telemedicine in a meaningful way with tests that have been researched and look at the validity and the sensitivity and specificity. And that research is coming out now, which tells you, yes, we're going to be able to deliver the care more effectively. And then once you can do it effectively, now you can bring telemedicine in and really deliver efficient, much more efficient care. It's more efficient for the patient. They don't have to come in and wait in the office. It's more efficient for the healthcare environment too, because you don't have to room a patient, it's not back and forth, no cleaning of rooms. Obviously not all care is appropriate over telemedicine, but a lot more than is currently being delivered will be delivered like that in 5 years.
Yeah, you and I are on the same page, different universe, but same page. I think it's a completely interconnected world, and that interconnection is just going to strengthen over time. So listen, I really want to thank you for your time. I know I can't imagine how busy an orthopedic spine surgeon is. And for you to do this other stuff with Mockingbird to help with the credentialing, I think is stupendous. And I want to do my part to help you. I want to help me help you. I don't know how you say it exactly, but I like the idea that you just get rid of the clutter and get down to the nitty gritty of taking care of people. I mean, let's face it, the day you're in a hospital for the average person is not the best day of their life.
It's not.
It's not. So whatever you can do to improve on that, I'm with you 100%. So thank you very much. For those of you on the webinar, if you have questions, I apologize. We'll get to them. Go ahead and ask them, and we'll follow up with you. And with that, Doctor, I appreciate your time very much.
Thank you. I really appreciate the opportunity.
pipeline allocations are also contributing to the issue. When air travel plummeted at the height of COVID, jet fuel suppliers reduced the amount that they sent through the pipelines that serve individual airports.